projection of the shoulder could be taken with three different rotation. It is external, neutral, and internal rotation. But before you proceed with rotating of the patient's hand, make sure that there's no suspected fracture or dislocation as it is contraindicated. So for this projection, the patient can be examined in an upright or supine position. But remember that shoulder and arm lesions, whether traumatic or pathologic in origin, are extremely sensitive to movement and pressure. So for this reason, the upright position should be used whenever possible. Okay, so center the shoulder joint to the midline of the grid and adjust the center of the image receptor to a point 1 inch inferior or below to the coracoid process. We can also place the patient in a slightly rotated position if necessary to overcome the curve of the shoulder structures so that we can place the body of the scapula parallel with the IR plane. And if the patient is in supine position, support the elevated shoulder, which is the non-radiographed part, with sandbags. So, to achieve external rotation of the humerus in shoulder AP projection, ask the patient to supinate the hand and abduct the arm slightly. So, this position places the shoulder and the entire humerus in true anatomic position. We can also see the greater tubercle laterally when the humerus is externally rotated. As for the neutral rotation of the proximal humerus, place the palm of the hand against the hip. This will place the greater tubercle in medial profile of the humeral head. And to place the proximal humerus in internal rotation, ask the patient to slightly flex his elbow and rotate the hand internally, so its posterior aspect is placed against the hip. Okay, so make sure that the humeral epicondyles are also perpendicular to the IR for internally rotated proximal humerus. So this will also visualize the lesser tubercle in profile on the medial aspect of the humeral head. For all of the position on shoulder AP projection, the central ray is directed perpendicular to a point 1 inch below or inferior to coracoid process. As for its structure shown, the greater tubercle and the site of insertion of infraspinatus tendon can be seen in shoulder AP projection in external rotation. And the posterior part of supraspinatus insertion as well as the greater tubercle partially superimposing the humeral head can be visualized in neutral rotation. The internal rotation will demonstrate the proximal humerus in true lateral position, and the site of insertion of the subscapular tendon can also be seen. Next is the transthoracic lateral projection Lorenz method. So this is used when trauma exists and the arm cannot be rotated or abducted because of an injury. For this projection, the patient is in lateral position before a vertical grid device, with their affected side in contact with the IR. Have the patient raise the uninjured arm and rest the forearm on the head and elevate the shoulder as much as possible. So this elevation will drop the injured side, separating the shoulders to prevent superimposition. So center the surgical neck of the affected humerus to the IR. The exposure of the transthoracic lateral projection is done in full inspiration. So having the lungs full of air improves the contrast and it decreases the exposure necessary to penetrate the body. So the central ray is directed perpendicular to the image receptor, entering the MCP at the level of surgical neck. So if the patient can elevate the unaffected shoulder, angle the central ray 10 to 15 degrees cephalad. So this projection will show the lateral image of the shoulder and the proximal humerus projected through the thorax. Alright. So next is the inferior superior axial projection of the shoulder joint, Lorenz method. So in this method, the patient is positioned in supine with the head, shoulders, and elbow is elevated at approximately 3 inches. So the affected arm is abducted as much as possible until it forms right angle to the long axis of the body. So keep the humerus in external rotation and have the patient's head turn away from the side being examined so that the vertical IR can be placed against the neck. So the central ray is directed horizontally through the axilla to the region of acromioclavicular articulation, and the degree of medial angulation is often between 15 to 30 degrees. The greater the abduction of the arm, the greater the angulation of the central ray. So the Lorenz method will show the proximal humerus, scapulohumeral joint, the lateral portion of the coracoid process, and the acromioclavicular articulation, as well as the insertion site of the subscapular tendon on the lesser tubercle of the humerus and the point of insertion of the teres minor tendon on the greater tubercle of the humerus are also shown. An anterior dislocation of the humeral head can result in a wedge-shaped compression fracture of the articular surface of the humeral head. It is called as the heel sacs defect. So this will be located on the posterolateral humeral head. So to see this defect, an exaggerated external rotation of the arm may be required with the same position of the Lorenz method. We have to rotate the arm externally in exaggeration until the thumb points downward. So this is what we call the Rafferty-Long modification. The central ray for this modification is directed horizontally and angled 15 degrees medially, entering the axilla and passing through the acromioclavicular joint. Another method in inferior superior axial projection is the West Point method. The patient is in prone position with the affected shoulder elevated 3 inches. Turn the patient's head away from the side being examined. Abduct the arm of the affected side 90 degrees and rotate so that the forearm rests over the edge of the table. Place a vertically supported IR against the superior aspect of the shoulder with the edge of the IR in contact with the neck. So the central ray is directed at a dual angle of 25 degrees anteriorly and 25 degrees medially. So this will enter at approximately 5 inches inferior and 1.5 inch medial to the acromial edge and exceeds the glenoid cavity. So this will visualize bony abnormalities of anterior inferior rim of the glenoid in patients with instability of the shoulder. It is also used to demonstrate the Pankhurst lesion and associated heel sacs defect. Next is the Clemens modification in inferior superior axial projection. So this is used when prone or supine position is not possible. The patient is placed in a lateral recumbent position, lying on the unaffected side. Abduct the affected arm 90 degrees and point it towards the ceiling. The IR is placed against the superior aspect of the patient's shoulder. The central ray is directed horizontally to the MCP, passing through the mid-axillary region of the shoulder. So if the patient can't abduct the arm at a full 90 degrees, angulate the central ray 5 to 15 degrees medially. The next projection is the superior inferior axial projection. So here, the patient is seated at the end of the radiographic table high enough to enable extension of the shoulder under examination. The IR is placed near the end of the table and parallel with its long axis. So have the patient lean laterally over the IR until the shoulder joint is over the midpoint of the image receptor. We have to rest the patient's elbow on the table and flex it 90 degrees with the hand in prone position. The central ray is directed 5 to 15 degrees through the shoulder joint towards the elbow. So this projection will show the joint relationship of the humerus and the glenoid cavity. The next projection is useful in diagnosing cases of posterior dislocation. It is the AP axial projection of the shoulder joint. The patient could be in upright or supine position and center the scapulohumeral joint of the affected shoulder to the midline of the grid. The central ray is directed at a cephalic angle of 35 degrees through the scapulohumeral joint. So for the last projection of the shoulder joint is the PA oblique projection in right anterior oblique or left anterior oblique position, or what we also call as scapular Y. This was described by Rubin, Gray, and Green and obtained its name as a result of the appearance of scapula. The body of the scapula forms the vertical component of the Y, and the acromion and coracoid process forms the upper lip. So this projection is useful in the evaluation of suspected shoulder dislocations. The patient is radiographed in the upright or recumbent position. If the patient is severely injured, modify the anterior oblique by placing the patient in the posterior oblique position. So the anterior surface of the affected shoulder is placed against the image receptor. Rotate the patient so that the MCP forms an angle of 45 to 60 degrees to the IR. Palpate the scapula and place its flat surface perpendicular to the image receptor. Position the center of the image receptor at the level of the scapulohumeral joint. The central ray is directed perpendicular to the shoulder joint. So in a normal shoulder, the humeral head is directed superimposed over the junction of the Y. In anterior dislocations, or what we also call as subcoracoid, the humeral head is beneath the coracoid. As for the posterior dislocations, or the subacromial dislocation, it is projected beneath the acromion process. So these are the projections for the shoulder joint, and on the next recorded lecture, we will learn the projections for the glenoid cavity. Please prepare for a short seat work on Friday, October 29, regarding the shoulder joint projections. Thank you so much.